which is a technique giving rather high doses of radiation, 8 to 10 millisieverts. And we are still using this technique in patients having great arrhythmia, or in ICU patient when we want to scan a patient very rapidly. And 8 to 10 millisievert is not a very elevated dose, and it is acceptable, especially in emergency situations. And this is achievable by new generation machines that are present now in the post-64 era. What is much more used nowadays is the prospective triggering technique. The idea is to give radiation not all through the ECG cycle, but to give the radiation dose only during the end diastolic phase, as you can see here. Then stop, then repeat only in the end diastolic phase. So we give a very small dose of radiation. And here we are speaking of 1, 2, or 3 millisieverts, which is really acceptable and is excellent for younger patients and is a very safe approach and very informative, giving us a lot of information. Much newer and very, very promising technique is the low KV technique combined with highly concentrated iodine. So we increase the amount of concentration of iodine we are giving to the patient from a concentration point of view, and we decrease our KV more and more. So we reach sub-millisievert dose, and still we get very nice images, which are slightly noisy, but are highly enough and very informative. So we have multiple techniques to decrease the radiation dose. Most common is the iterative reconstruction and the automatic exposure control. The idea, as we said before, is not to give a continuous amount of radiation during the examination, but to give it only during the end diastolic phase and stop, and giving it back again during the next end diastolic phase, and so on. We call that iterative dose reconstruction technique. This is very important because it really decreases the amount of radiation and it gives us very safe exam for the patients. And we are really using these techniques in our center, and it's very crucial for us and very important because radiation is a very important issue for us. So 15 years ago, we were getting these type of images. We called it a CT chest examination. And as you can see, it was very difficult for us to properly delineate the heart, to see the coronaries. The resolution was low. Why? Because this examination wasn't ECG gated. All our examinations are done ECG gated. We put some ECG leads on the abdomen of the patient, on the thorax of the patient, and we acquire what we call an ECG gated image. And this is the type of image we get. Very high resolution images, 0.5 millimeter thickness, low radiation, no artifacts at all. The coronaries are very clear. The aorta is very clear. The pulmonary artery is very clear. And all the cardiac chambers are very clear. Amazing quality of images. Of course, we can focus our job on the heart, but we can also focus and apply this technique on every artery in the body. We can go for some very nice images in the hand, for example, digital angiographic examination of the digits. You can see the axillary arteries. You can go for renal arteries with very high resolution images. Same for patients having some obstructions. You can see the quality of images, how they are nice. You can see here the anastomosis. For liver transplant protocol, all that with very high sensitivity. So I mean by this slide, if we can get very nice images of the coronary, we can, of course, visualize any artery in the body without any problem. Same for pediatric population. We can now speak of scanning small children because now we have low radiation technique, so there is no risk for the children. We can do for them a very nice sub-millisievert dose examination and get amazing quality of images. Like for example, this patient, small child, was coming for us for a post-operative follow-up. As you can see, he has a shunt here, and the shunt here is more nicely seen in a coronary reconstruction. But if it is not clear enough for the surgeon, we can do and go for some 3D reconstruction, and you can see the blood tossing shunt, this shunt here, and you can see that this shunt is totally patent and there is no problem. And actually, cardiosurgeons like this type of images, and they ask us for more and more images like that. And even they want to use CT as a sort of platform or a preoperative exam for them. And they ask for several views: aortic views, pulmonary view, right anterior oblique, left anterior oblique, and they want us to always give them these type of images because they make life much easier for them. Again, another case, sub-millisievert dose, below 1 millisievert. You see the quality of images, how it is amazing. This patient had no pulmonary artery. And here, the right and left pulmonary artery are directly arising from the aorta, as you can see here. It's an amazing and very rare case, a pseudotruncus case. Let's return to coronary imaging. Where are we? We have a lot of magazines, as you can see, that are speaking of non-invasive cardiac imaging. There is no doubt multi-detector CT has entered the field. It's totally present now everywhere, in all magazines and in all clinics. Why that? Because of a very high sensitivity. If you compare coronary CT to exercise ECG or nuke medicine, you can see that the sensitivity is much higher. It's a very robust technique with a very high negative predictive values, as you can see in this summary of a lot of studies by many authors. And still we are speaking of very low dose for this very safe exam. So the question is, where to go if we have a patient with chest pain? What to do? Go for a CAS or go for a CT? I think the answer is clear. Sure, CT is safer, much more informative. And let me explain you in an ABC rule rapidly how we will perform this examination and what is the idea. First of all, we begin with what we call a calcium score. So we scan the patient ECG gated without giving any contrast. And we like to use this large field of view as published in this, like seen in this paper I published, because we can see in this calcium score technique with a large field of view, we can revise the chest entirely. Maybe we can detect some accidental findings, like for example, these pulmonary nodules. So it's very important to perform this calcium score, first of all, to calculate the amount of calcium that is present in the arteries, and the more the calcium increase, the more the risk of coronary artery disease increase, but also to detect any accidental findings. This is the first part, without contrast. Then we inject contrast, and we get a lot of images, actually, around 500 images of superb quality images. And I'll try to show you a little the anatomy, how it goes. You can see here the left anterior descending artery going and heading towards the apex of the heart. You can see here the right coronary artery arising from the right coronary cusp and going down, down, down on the right side of the heart and giving the posterior descending artery at the base of the heart. And you can see here, lastly, the LCX, the circumflex here, curving around the left atrial appendage and giving the obtuse marginal artery to the left ventricle. Anatomy is rather easy. This is the aorta, this is the pulmonary artery, left ventricle, left atrium in which the 4 pulmonary veins are entering, which is a normal situation. You can see the 4 pulmonary veins nicely, and right atrium in which the coronary sinus is entering. This is a little resume of the anatomy of cardiac imaging. And lastly, the last portion of our examination, after the calcium scoring, after injecting contrast, is a functional examination that we can perform, and we can get this type of images, amazing images. We can see the heart contracting, and even if there is a complication like this thrombus here present in the apex of the heart, we can nicely see. And we can also comment on the contractility of the heart and look for any dyskinesia, hypokinesia, any wall motion abnormality can nicely be seen. So CT coronary exam is a very comprehensive, complete examination, giving information about the chest, if there is any abnormality, as this case with a bronchogenic, for example, giving information about the coronaries, if they are patent, giving information about the calcium score, if there is increase in the calcium score, and lastly, giving information about the contractility of the left ventricle and any associated information. Of course, as we have a very high resolution, we can, of course, comment on very, very small anomalies, for example, coronary anomalies. Normally, the left main and the LED and LCX are arising from the left coronary cusp, but sometimes we have some abnormalities, like, for example, trifurcation, which is a normal variant. But we can have another situation in which the left main is not arising from the left coronary cusp, but it is arising from the non-coronary cusp. We call it ectopic left main, and it's not a great problem, actually. But what could be problematic, and it's very important to report, is what we call a malignant course of left main. Here, the left main is not arising from the left coronary cusp, but it is arising from the right coronary cusp. So it is squeezed between the pulmonary artery and the aorta. Pulmonary artery and aorta have high pressure, so the left main here is squeezed, and this is a dangerous situation, and it can lead to sudden cardiac death. So you see, with very high resolution, we can detect very small anomalies, and it's really, really interesting to get these type of information in our reports. For example, this patient, this is a normal patient. We have the right coronary artery here arising from the right coronary cusp. This is a normal situation. And here we have a right coronary artery squeezed between the pulmonary and the aorta. This is a malignant course of the right coronary artery. And this patient was really unlucky, and he had pulmonary hypertension. You can see the pulmonary arteries are very big, and you can see the right side, the right cardiac chambers are very big, the right ventricle and the right atrium. So the pressure in the pulmonary artery was higher and was squeezing more and more this poor right coronary artery that was squeezed between the pulmonary and the aorta. So this is a malignant course, and this is an urgent situation. Another one, to show you how the resolution is amazing. You can see that there is a problem here in the LED. It is too big, and it is dilated, and maybe connected with this right ventricular chamber. Difficult to assess. So we went for some reconstruction, curved MPR and S3D, and you can see there is a dilatation within the LED, opening into a small sac, and this sac is communicating with the right ventricle. This is an LED RV fistula. Wow, we can get it with CT. Yes, we can. Another one, we can see this section. As we said, we have a very high spatial resolution with CT, and we are going up to 0.5 millimeter, and you can see that we can even see the dissection line within the coronary artery. So really amazing applications. Let me give you some updates from the last conferences from the European Society of Cardiac Radiology a few months ago. I will give you some updates. They were speaking of what? Of course, we have guidelines as regard the interpretation of the degree of stenosis. And now, for normal coronaries, it's advised to go for follow-up. If we have a small plaque causing less than 25% occlusion, we can go for follow-up or medication. Same for mild occlusion, up to 50%. But if we have a moderate occlusion, up to 70%, we can here need more investigation, like FFR, I will explain it later, or SPECT-NUC, or MRI examination. And if we have a severe occlusion, more than 70%, as in this patient, for example, here this patient will need a PCI, will need stenting, or will need CABG, according to the degree of occlusion, if it is total or subtotal. So these are the new guidelines published 1 year ago. Of course, we have some gray zones. And here I'm speaking of intermediate degree of coronary artery stenosis, the area between 50 and 70% occlusion. This type of lesions. It's difficult to know if this occlusion is causing a hemodynamic effect distal to the side of occlusion or not. This is a rather difficult question for us in CT. But there are very interesting techniques that are coming. One of them is the fractional flow reserve, the FFR-CT. Actually, this technique is used in angio. It is a hard and time-consuming technique. But now it is coming to the CT. Actually, it is a software, nothing more, that is calculating automatically the pressure before the site of occlusion and the pressure after the site of occlusion. If above 0.7, this is normal. If below 0.7, this is significant. Let's take a very rapid example. This is a patient having a problem. His FFRCT below the site of occlusion was normal, and after the site of occlusion was 0.6. So there is a significant occlusion. There is a hemodynamic effect. So we are confirming that the borderline lesion here is having a hemodynamic effect. So this is very, very informative for us and for the cardiologist, of course. And this is the situation after stenting. You can see that the pressure got high again, above 0.7. So it got normal. So this FFRCT technique is coming, very promising, very increasing the sensitivity and specificity in regards to CT alone. If we're speaking of CT alone, we have a lower specificity. If we combine it with FFR technique, we increase our specificity. And we get very near to numbers as regard the intervention angio. So FFR technique is a promising technique, and it's coming. It's a little expensive, but it will be combined with CT, and it will come with future CT machine. It will drop the need for functional tests, aspect and stress echo and perfusion MR, and it will be surely very cost effective in few years. Another interesting technique we are having now on our machines is a software that automatically removes the excessive amount of calcium and the excessive amount and the stents if there are two causing artifact, like in this case. So this is before post-processing, and this is after post-processing. You can see that the area that was not clear here in the LED because of high degree of calcification and high degree and the stent that was causing a lot of artifacts, you can see after subtraction that the LED is totally normal and free from occlusion. Very nice imaging. Of course, we have no problem with stents as far that we're speaking of stents above 2.5 millimeter in diameter. You can see inside of the stent if there is occlusion or not. We can zoom inside, and you can see that this stent here, we have some black material. We call it neointimal hyperplasia, and this black material is causing occlusion of the stent. New type of stents we call bioresorbable stents are coming in the market. These type of stents are totally transparent, causing no artifact. We recognize them by looking for these two metallic points, landmarks that are present in the proximal portion and the distal portion of the stent. And you can see them here in CT. This is the proximal and the distal one. And you can see that this very nice resorbable stent, our bioresorbable stent, makes life for us much easier. And it's a really, really promising stent for us. It will give us and allow us to have nicer images as regards CT and MR, and it can leave the natural course of the vessels, the coronary vessel, for a longer